Hi, everybody. I'm Wendy Murdoch, and this is Webinars with Wendy. I've been doing a series of webinars during the pandemic, and I'm coming up to 1 year being off the road and doing these webinars. This is number 177. I had no idea we were going to be doing this many, but it's really great, and I really enjoy all the wonderful guests that I've had. Tonight is Dr. Maureen Kelleher, and she's at the Marion Dupont, what's the rest of the name? Marion Dupont?
Scott. Marion Dupont Scott Equine Medical Center.
Thanks. Yeah, I think
Mouthful.
is just the abbreviation. Yeah, which is a rehab center in Leesburg, Virginia. So welcome, Maureen. Thank you so much for joining me tonight.
I am happy to be here. Thank you, Wendy.
So Maureen, can you just give us a little bit of your background for my guests?
Yeah, so I came to, Marion Dupont Scott is in Leesburg, Virginia. And I came here about 3.5 years ago from California. Most of my veterinary education and experiences have been in California. I went to vet school at UC Davis and did an internship at Pioneer Equine, which does a lot of performance horse work, a lot of Western performance horse work, but some English performance horses. And that's where I sort of got my sports horse, sport medicine bug, and then went and worked for a practice that did predominantly English performance horses, a lot of show work, so working at the shows and that kind of thing, and definitely had lots of soft tissue and bone injuries to rehab in some of these higher end horses. And then I went and did a surgical residency back at UC Davis, and then went right back after my residency to managing performance horses. And so that's really been my focus. It is performance horse injuries, rehabilitation, imaging, diagnostic imaging, that kind of stuff.
Do you see a big difference in injuries for like dressage horses and Western competition horses?
Not really, but what I will say is I think that the susceptibility comes from a different aspect. So if you look at some of the quarter horses and how their body types are and how their breeding has come along through the years, they're a big, stocky horse with little tiny feet. And so there's definitely a genetic component, with some of them having some predisposition to navicular issues. So I think while the actual injury type looks the same on diagnostic imaging, I think that where they come from, it differs a bit. So the quarter horses may have some genetic predisposition that tips them over the edge to injury, whereas some of the dressage horses or even jumpers may not come so much from breeding or their breed predisposition, but just their individual conformation and their job.
Yeah. And of course I have to ask, were you a horse crazy kid and rode as a kid?
Yep. So definitely had little briars when I was little, and then started riding, I think when I was about 8 or 10, and then got my first my own horse when I was 12. So yeah, I've been a horse owner, horse lover since I can ever remember.
Awesome. And so vet school was just on your radar the whole time?
Yeah, I actually did a lot of riding. I didn't go to college right away after high school, and mostly rode horses. Did a little bit of work training horses, and then finally decided I needed to get my act together and do something else with my life, because training doesn't always pay the bills as much as you'd like it to. So, but I was happy. I think that may be one of the reasons why I landed in the sport horse, performance horse medicine aspect of things.
And what brought you to Virginia? I mean, it's quite a different climate than California.
Yes. So if any of you are show horse people or horse show people, you know that you can be on the road traveling a bit, going from show to show to show. And I had been doing that for many years and was getting a little tired of traveling from show to show, and so started looking for different opportunities. And a friend of mine that I did my residency with is an internist here at Marion Dupont Scott, and she sort of encouraged me to apply for a new position that they were posting, which happened to be sports medicine. So I think there was somebody up there looking out for me.
Oh, nice. So that's a fairly recent addition to Marion Dupont Scott then.
Yep. Yes. Yep.
Can you tell us a little bit about that facility? It's been around for a long time, but I'm not sure everybody knows about it.
Yeah, so it has been around for probably about 30 years now. It's in Northern Virginia and does serve Virginia, Maryland, West Virginia, Pennsylvania. So we do get horses from all over, even all the way from North Carolina. We are a satellite hospital of the veterinary hospital that's based out of Virginia Tech in Blacksburg. So the main vet school and the main vet hospital is in Blacksburg, which is in Southern Virginia, southwestern Virginia, excuse me. And this Marion Dupont Scott was basically, we were granted the land. Morven Park is surrounding us. And so the land was donated for the hospital, and then Marion Dupont Scott donated the money to start the hospital. So we are an educational institution being part of the vet school. So we also have residents, we have students that come and rotate through our hospital, and then all of the faculty members do have some teaching and research positions as well, or commitments. And we see everything. Basically, we have board certified internists, board certified surgeons, board certified sports medicine and rehab specialists. We have many imaging modalities, so from MRI to CT scans to X-ray, ultrasound, all kinds of endoscopy, so upper airway endoscopy, gastroscopy. We can do laparoscopy. We've got 2 surgical suites, and so we do a lot of emergency work as well as elective surgeries, so lots of colics, lacerations, all kinds of things there. So so we have a pretty broad spectrum of imaging, diagnostics, and therapeutic options. And then with my addition, we've been building our rehab services. So we have quite a few rehabilitation services available now as well. Besides the Surefoot pads, we have laser therapy, we have shockwave therapy, we have vibration floor therapy. I do chiropractic and acupuncture as well. I'm trying to think what else. We have a cold compression, warm compression machine as well.
It sounds like you've got all the bells and whistles.
Yeah, definitely. So we do some post-surgical rehab, and then just regular old non-surgical tendon, ligament, joint, bone rehab as well.
And just approximately how many horses a year do you see for sports medicine related?
Oh, that's a good question. That is a very good question. I know the hospital sees on average about 2,500 to 3,000 patients a year. So I would say, you know, the sports medicine, I think our emergency caseload is probably pretty high and accounts for a good proportion of those. But I would say probably, I mean, I myself personally probably say anywhere from 2 to 5 appointments a day. So, you know, probably a fair number of, you know, in the hundreds of cases a year for sure.
Wow. And so sports medicine in the United States is something that's it seems to me that it's a newer concept, that to treat horses more like athletes, to do physical therapy, to be proactive and catch it before it's a serious injury. You know, I know when I go to Europe, it's particularly Germany, equine physical therapists is what they're, or animal physical therapists over there is a well-known profession. And I know I have quite a few people actually as part of the Surefoot team that are animal physical therapists that use Surefoot in their practice. Whereas in this country, it seems like we're just beginning to really wrap our brains around this idea that we need to be doing physical therapy with these horses because they are athletes. We need to treat them that way.
Yeah. Yeah, I think that's absolutely true. I do think other parts of the world are a titch ahead of us as far as at least the idea that physiotherapy in animals, and that really comes down to mostly equine and canine, because those are the athletic animals out there. Not to say that you won't go into a small animal rehab facility and see a cat on occasion. I've seen cats in water treadmills, believe it or not. Yeah. If you guys ever want to watch anything fun, just go to YouTube and look for cats in water treadmills. But you know, the canine, I think really what sort of got things fired up in the US was not actually equine, which is a little surprising because we do have quite a huge horse industry in this country, and we have you know, a good selection of every caliber of horse available, from really upper echelon, very expensive horses to not very expensive, but very well loved horses in people's backyard. But I think it was the canine, you know, the agility dogs and the flyball dogs and the military and police working dogs that really led the way in this country. I think a lot of those dogs, especially the working dogs, are a significant investment for, you know, the police and the military. And so they started to, I mean, those military working dogs, they are soldiers, and they have, you know, for lack of a better term, they have dog tags and they have military IDs. And so my impression is that they started seeing these as valuable resources that you would treat the same way as any of your other human valuable resources in rehabilitation. So, and then I think as it caught on in canine, the canine world, a lot of equine people went, well, wait a second, we can do that with horses too. I do think the area that the equine world has pushed the envelope is with regenerative medicine. So biologic treatments in the form of stem cells or PRP or any of the biologic products for treating joints and tendons and ligaments. And so I do think, you know, that is where the equine world kind of pushed it. And now I think there's a really nice crossover where canine people can get a lot out of the equine world, and the equine world can get a lot out of the canine research as well.
That's awesome. And yeah, and I think, you know, we have such a huge investment in these horses that to not think of them as athletes that need the same kind of care as any athlete, even if it's like a trail horse, it's still athletic. It's carrying a rider, you know, up and down hills, especially around here, rocky surfaces, down through rivers. You know, you know, an injury is really expensive. So preventative care obviously is always the place to be, not at your place.
Yes, exactly. Yes. And, you know, I think also a lot of people say, well, if I go out and twist my ankle and go see the doctor, they're going to send me to the physical therapist until I feel better. And why shouldn't, you know, if my horse goes and twists his foot, you know, why shouldn't I do the same thing for him, especially if I want him or her to come back and do the same job that I was asking him to do before he hurt himself. So you know, so I think, you know, horse owners today expect a lot of their horses, and in return, they give them back a lot, you know, try to take care of them quite well, prevent injuries. But then if they do get injured, they take very good care of them and get them back on their feet, which is
Yeah,
good.
and more that the general awareness of rehabilitation and cross training and fitness, it's really, we're really starting to figure this thing out, which is great. So one more question before we get into your talk. Do people bring their horses to Marion Dupont Scott for physical rehab, or do you have people that actually go out to the horses? Is it, which way is it?
Right now they come here. We don't have any ambulatory service, so to speak. I hope someday that we will, my dream someday would be to do basically a little bit of telemedicine with some other vets, and consult, see what resources are available to the area, and then help people come up with a good rehab plan. The other thing is, we have several of our technicians and nursing staff that are very good, and have training in rehabilitation. And so as we grow and the rehab part of our practice grows, I would love to have an opportunity to send them out into our area, because I think it's also very beneficial for the horses to have some of these things right where they are, instead of having to haul them here all the time. They can stay here. So I do have again, definitely horses that may come in for arthroscopic surgery or tendon surgery or joint surgery. They'll stay, instead of going home, you know, after the surgery for, you know, if the normal horse goes home in 2 days, maybe they'll stay a week or 2 weeks afterwards, and we'll do some of the initial post-operative rehab, and then they'll go home to get picked up by either their regular vet or maybe go to a proper rehab center. But yeah, I think that there's a lot of growth in the equine rehabilitation section of our industry, and I do think that you know, there are a few, there's actually a few people in our area who are certified tech like therapists, that do a lot of farm calls. I definitely recommend several different people in our locale. Maryland has a couple of nice people that go out to the farm and have different modalities available to them, which I think is really good.
Yeah, because I know there's the CERP and the CERT training.
Mhm.
Is that something that Virginia Tech are they ever going to consider doing something like that?
I don't know. I would love that. University of Tennessee has like a top-notch program, and they definitely got people coming from all over the world to take that program. The techs that we have that have an interest in rehab have done that program. It's a very in-depth program. I think down the line, as we build our rehab practice, my hope would be to set up something where we could train people as well. We are a university, and one of our missions is to educate. So that would be
awesome.
fantastic. Yeah.
Great. All right. So let's dive into your topic here. I'm just going to make sure that all set.
Okay. I can go ahead. Let me share.
Yep. I should be able to screen share.
Okay. So I only have a couple of slides, and certainly I can just do a brief overview, and then we can do questions and that kind of thing. The biggest thing I wanted to chat about today is deep digital flexor tendon injuries in the foot. So if any of you know the anatomy of the limb very well, they do have the horse does have a deep digital flexor tendon, both front and hind legs. And it starts pretty high up, and it starts as a muscle. It is a tendon, so it starts as a muscle. And then as it comes down, it changes from muscle tissue to tendinous tissue, which is very firm, more fibrous tissue. And it comes all the way down the back of the leg to insert on the bottom of the coffin bone. So starts in the front leg, starts all the way up by the elbow, and in the hind leg up above the hock. So it's a very long musculotendinous structure.
Can you just use your pointer to
Sure.
trace it down on the, because I
Yeah.
can see your pointer. There we go. Awesome.
This guy right here is our deep digital flexor tendon down in our foot. And so here's our coffin bone on the half shell, and our navicular bone, and our short pastern, long pastern bone, and the end of our cannon bone. And you can see this arrow pointing upward is, this guy doesn't stop here just because the picture stops. It goes all the way up. But you can see it's kind of glistening white tissue, very long linear fibers that come all the way down. Now, there are some other soft tissues in the back of the pastern that come down into the foot. But the main one that I want to kind of focus on is this deep digital flexor tendon, because this area is a focus of injuries for the deep digital flexor tendon. So while it can get injured anywhere along its length, I would say probably the most common location when you hear about a deep digital flexor tendon injury is going to be down in the foot area, so within the hoof capsule. And then even if we were to say from about the level of the pastern joint lower, if we were to break that up into the section that was most prone to injury, it's going to be right here in the navicular area. And if you kind of look at it, it makes sense. Obviously, this specimen is no longer alive, and so it's not bearing weight on its foot. So this does have a gentle curve around the navicular bone. But if you think about a horse that might be standing on this foot, you could see that a lot of weight is going to come down and compress along this deep digital flexor tendon. And then it's got this curved area which it has to surpass. So depending on the horse's foot conformation, we could have more or less stressors in this area. And certainly we've heard lots of horror stories about the navicular bone itself and how prone to injury this guy can be. And so because of their close association, we tend to put the complex of navicular syndrome or navicular disease to mean anything that happens in this area, meaning injury to the bone, injury, this little space here, I'll show you in the other picture, is the Navicular Bursa and our deep digital flexor tendon. And then there's a few other soft tissues that kind of hold the navicular bone in place. So if we go to this blown up picture, here's our deep digital flexor tendon curving along the back of the navicular bone. And then this space where the bluer arrows are, that's our Navicular Bursa, which is a synovial structure, so very similar to a joint. So it's surrounded by soft tissue, and within that space is synovial fluid, so a thick, well, ideally a thick viscous fluid that helps this deep digital flexor tendon glide along the back of the navicular bone. So when the horse is moving, it's helping to prevent this from getting stuck over the navicular bone. We want a nice smooth gliding surface so the horse can bear weight, spring off the ground, and move, propel itself forward.
You know, it's looking at these pictures and listening to you, suddenly you realize the entire horse, 1,500 pounds, say my horse, is dependent on that tendon crossing that navicular bone.
Yes,
I mean,
absolutely. Mhm.
all of a sudden it's frightening. It's
Yes.
such a tiny little space.
Yes. And you can understand why then when somebody comes in and has an MRI and finds out that their horse has a deep digital flexor tendon injury down here in this area, it's a pretty serious, you know, it's pretty serious news. And that's sort of what I want to talk about a little bit today, is because, you know, I do a lot of MRI imaging, and there's a wide gradation of these injuries. And so there are times when I say, hey, you know, let's not panic. And there are other times when I say, okay, this is not good. Um, and yes, not only does all of the weight and the force of the horse's limb come transmit down and be basically pushed against this small area, which then has to spring back and you know, help propel this horse forward. You know, if we have poor foot conformation, so either inherent in the animal, meaning it was born with poor conformation, or due to poor trimming and shoeing, or poor hoof care, a lot of those factors also go into play into how much stress and strain gets put on this area of the foot. So one of the things that we do when we diagnose a horse with a deep digital flexor tendon injury is get the foot in better balance. So number one treatment is going to be to make sure that foot doesn't have any undue stress on it, and that deep digital flexor tendon doesn't have any undue stress. So if the horse has a very broken back angle, we're going to need to lift that up a little bit to get some of the stress off that deep digital flexor tendon, and vice versa. If somehow the leg is becoming very contracted, and the horse is very club-footed, the deep digital flexor tendon is becoming tighter, which in itself can be painful. And so gradually we want to do some work on the foot to lower that heel over time to see if we can get a little stretch on the deep digital flexor tendon, so that it becomes more elastic and less rigid.
Is MRI pretty much the only way you're going to see these types of injuries?
Yeah, absolutely. With some fairly tedious, I think, preparation, you can do a limited view of the foot with ultrasound. So certainly we can take radiographs, which will give us a good look at all the bony structures, but not give us any information on the soft tissues. As far as ultrasound goes, which, you know, anywhere else in the body, ultrasound is my absolute 100% favorite imaging modality. You can nearly look at just about anything with an ultrasound. But because of the rigidity of the hoof capsule, the echoes or the ultrasound waves can't really penetrate the hoof capsule unless the hoof has been soaked in water. And then you still only have a very limited window and only really kind of see the surfaces of things. So if you really need to find out what's going on in the foot, your best bet really is to do an MRI. And I know a lot of people say, well, but they can do an MRI or they can do an ultrasound for $300 or $400. And I say, okay, but if they don't get a diagnosis or don't get the correct diagnosis because the imaging is difficult, then you've wasted that $300 or $400 that you could have used to get the imaging that's going to give you the absolute answers that you need. Most, there's multiple places to get MRIs done in this country. There's probably one within 2 hours of every horse in this country. And there's different types of MRI. You'll hear discussions about low field, high field. Low field MRI just means that they can be done standing. There was a stigma for quite some time that the low field MRIs were not diagnostic or not diagnostic enough. And I don't think that's the case anymore. I actually prefer all of my foot MRIs to be done with the low field and standing. Very, very rarely do we come up with a non-diagnosis. And I think that there's a good percentage of those that we may get a non-diagnosis with a low field that we probably would get a non-diagnosis with a high field as well. It's just something physiologic that we have yet to come up with the form of diagnostic that's going to be most beneficial for every injury, especially bone injuries.
So, can I just ask, the MRI that you have that I've seen, is that a low field?
That is low field. Yep.
Okay. And then is there an importance to having the foot under load? In other words, the horse standing when you do that?
Yes and no. So I do think that is beneficial in some cases, but then in others, because it is under load. So if you take, for example, even the deep digital flexor tendon, if you've got a very fine split and it's under load, then those fibers are going to be squished together, so to speak, versus if they're non-weight bearing, then there might be a gap where you could see that. Now, down in the foot, I think that's much less likely to occur as it would up in the fetlock area, where it's more common for horses to get linear splits, and then we ultrasound them in a weight bearing stance, and it's very hard for us to see those linear splits in a weight bearing stance. But it's also very common and very easy for us to, when we're ultrasounding, to pick up the leg and get a dynamic ultrasound so that we can get some of that relaxation of the deep digital flexor tendon up in the fetlock and be able to see some of the linear splits there. There's not been a means to do a non-weight bearing MRI in the sedated horse. We can use that same MRI machinery to do general anesthesia MRIs. So as if I'm MRIing something up the leg, depending on the horse, we will do standing fetlock MRI as well. But once we sort of get past the fetlock, or if we've got a horse that's either very painful or not very patient, I usually recommend that even the fetlock be done under general anesthesia because of the motion that can happen. So down in the foot, they're very stable, and the foot hardly moves at all. And so there's not a lot of motion artifact. We get very nice images. But even in the most statuesque horse, as we propagate up the leg, there's micro motion that affects the images. So while I could say, yeah, sure, we can do a standing MRI of the proximal suspensory, even if the horse is being 100% perfect and it doesn't even look perceivably like they're moving, there will be motion artifact. So when I really want to get good images of somewhere up in the higher up in the leg, then I usually will put them under general anesthesia to get the most out of my imaging. But yes, the one we have is low field. And even again, with that under general anesthesia, we get beautiful pictures, and it's very, very rare that we get a non-diagnosis.
What's sort of the average cost of MRI for the front feet?
Yeah, so we have a package at EMC, which basically the horse comes in and has all the prep done, which we have to take the shoes off. We have to take x-rays to make sure there's no little metal fragments from the horseshoes in their foot. We put a little catheter in, they're sedated. Sometimes if they're uncomfortable, we block their feet so they're more comfortable. And our general price for 1 foot is $1,750. So yeah, it's an investment. And if we do both feet, I think it's $2,750. So the second foot is $1,000 more, not double. And I think that's probably pretty average across the country.
So for a horse to wind up needing to have an MRI, I would assume that they've already had a workup. Somebody's already looked at them. They've tried some other things. The horse is still lame.
Yep.
And so you've kind of gone through your process before you get to this point.
Yes. Yes. It really depends a little bit on the owner and the horse. There's very rarely times where the very first time I see the horse, and unless it's already had a little bit of workup done by another vet, or the vet's very suspicious that the horse might need an MRI. It's very rare for me to see a horse for the first time, localize the lameness to the foot, and then say, let's do an MRI. I'll go a little bit more traditional route, which is take x-rays. A lot of times there's definitely some trimming and shoeing changes that could definitely benefit the horse. So I'll do some treatment that wise, maybe make some exercise recommendations, etc., before I jump to MRI. Now, there are a subset of people who say, I want to know everything right now about my horse, and I'd rather know that there's not that much wrong and it's okay to just do those changes and go on. And so sure, if somebody wants to get an MRI for a horse that has a foot lameness, I'm not going to say no, but I also am not going to expect somebody to spend $1,750 or $2,750 the first time they come see me just to get them, to do an MRI. There are plenty of foot lamenesses that need, a little bit of shoeing treatment, a little bit of this, a little bit of that, and they'll be fine. So I don't think you have to do an MRI. But if you've got a lameness that's either severe and can't be diagnosed, or that has continued despite all of your interventions, then the only way you're really going to get an answer about what's going on in that foot is to do an MRI. And I have had lots of cases come in where the horse has been x-rayed upside down and this way and that way, and they can't find anything wrong. And I will find a fracture, and everybody will say, well, how come I didn't see that fracture on the radiographs? Well, they're the foot is a 3-dimensional item. And the only way you're ever going to see a fracture on a radiograph is when you shoot your x-ray beam directly down the line of that fracture. So if you don't get it just right, you may never see that fracture until you do an MRI and get all the different views and planes of that foot region. So and that's part of the thing too, with even with really good preparation, ultrasound of the deep digital flexor tendon is not going to give us all of the answers about that tendon. There's lots of intricacies that we can see with the MRI that we can't see with the ultrasound.
So basically then, a horse presents with a foot lameness, you do a standard workup, take some x-rays, look at the trim, improve the trim, maybe try some pain relieving medication, see if that improves the horse. And then you kind of go, okay, this horse isn't improving. We need to get a better picture. Let's do an MRI. Is that kind of the process?
Yep. Absolutely. Yep. And then afterwards, for me, I've been looking at MRIs probably for about 15 years now. So I would say in about 98% of cases, I can look at the MRI and I know what's going on, and can come up with a treatment plan fairly quickly. Regardless, I send all of my MRIs to a radiologist for review. I might miss something. I'm not a radiologist. I am a surgeon, sports medicine person. And so I always like for the radiologist to take a look at it as well, confirm, number one, that I see what I'm seeing, and to make sure that I don't miss anything subtle or not obvious or something like that. And then usually I come up with a treatment plan of various degrees. So when somebody comes to see me, and if there's anybody out there who has seen me, I give people sometimes maybe too many options, but I break it down into conservative, middle of the road, and aggressive treatment options. And so that gives everybody the chance, especially, just doing the MRI might have blown your entire budget. And then, you now that you know what it is, that's probably the most important thing we needed. So if you didn't have enough money saved to do really high end treatments, that's okay, because there's a lot of things you can do that don't cost you anything but time. So certainly controlled exercise is free as long as that's time, and your time and the horse's time. And then there's definitely some physical therapy or rehabilitation things that can be done that again are relatively cost effective. There are some medications, non-steroidal anti-inflammatory medications. Definitely they can have some side effects, but a short course can definitely decrease the inflammation, make the horse feel better. Most of the time you always are having a farrier come out to work on your horse's feet so we can get a proper shoe on, a proper trim. So I work with a lot of farriers in our area with different cases just to make sure that we're all on the same page. I understand from the farrier's point of view that not every shoe option is available for every horse, just because of quality and conformation and that kind of thing. So I try to work really hard with the farriers based on the horse's foot quality, what's wrong with the horse, what kind of rehab they're going to do, and what the farrier's capabilities and preferences are, so that we can get that horse into a nice balanced shoe that's going to be supportive of the injury and rehab. So I definitely think that there's definitely lots of options afterwards, from very conservative treatment to injections, and then even surgical interventions at some points. Yeah.
Wow. All right. So I'm not quite sure how to phrase this question, but given the number of horses that you've looked at with MRI for foot DDFT injuries, what percentage of those horses have a balanced foot?
I would say a small percentage, honestly, or the injury was present before the attempt at balancing the foot happened. So for example, horse comes up lame, the vet goes out, localizes it to foot, takes some x-rays, says the horse's foot is off balance, let's work on the shoeing, let's do that. And they give that a go for 2, 3, 4 shoeing cycles, the horse doesn't get better, comes in. In those cases, there's been an attempt made to get the horse balanced, but at the time of injury, was the horse balanced? Probably not. So I would say in my mind, there's a big correlation between the amount of balance in the foot, and a deep digital flexor tendon injury. Now, that said, there are some horses that, despite everybody's best effort, their hoof conformation is less than perfect. And so it could be trimmed and shod as perfectly as that horse is possible to be trimmed and shod, and it still could get an injury. And it's not the owner's fault. It's not the farrier's fault. It's just the horse's conformation. And then beyond that, you know, they are athletes, all doing different jobs, and certainly soft tissue injuries can happen acutely. So some of these injuries are chronic repetitive trauma to the deep digital flexor tendon, but some of them are, you know, an acute misstep or a slip in the mud or a crash into a fence or whatever. So it could have the most perfect conformation, most perfectly balanced foot, but have an acute traumatic injury to the deep digital flexor tendon. But I do think that almost every horse I see with an MRI, with a deep digital flexor tendon injury, has some room to improve in the foot balance department.
Yeah. So do you ever find that there's also a nutritional component to these injuries, or is it pretty much a structural, mechanical?
That's a good question. And I guess I don't think we have enough information there. I think nutrition is also one of those subjects that has always been sort of there in the background in the equine industry, and is now starting to be investigated and incorporated into the whole management plan of the horse a little bit more than it used to be. I think, you know, 20 years ago, or even, you know, we let the feed companies decide what to feed our horses. And now we're realizing that there's probably a little bit more to the nutritional balance. You know, certainly they can have be over nutritioned and have poor mineral balances, even if they're getting lots of food. They can also be under nutritioned because they're not getting enough groceries, or they're not getting the right kind of groceries. And certainly hoof quality is reflected in their diet. So certainly there's every part of the horse is connected to every other part of the horse. So, you know, I can't say with certainty that there isn't something to it. But I don't know if there's ever been a direct one-to-one link.
Right. What percentage of the injuries that you see are acute versus chronic?
I would say for the deep digital flexor tendon, it's probably about an 80-20 split. About 80% of them are chronic repetitive, and about 20% of them are an acute injury. Again, just because of how the horse is, you know, the body type, the foot, what it does for a living, how it's balanced, etc.
Yeah.
They start as, I would say the most common history that I get is, well, he was lame 2 years ago, and then he got better, and then he became lame again, but then he got better, and he got lame again, but he got better. So, you know, this cyclical sort of lameness where the horse comes up lame, we rest him, he gets better, we put him back to work, does well for a little while, hurts himself again, same foot, rested, gets better. And so what happens is they get a small little injury to their deep digital flexor tendon, we rest them, they feel better, we work them, it recurs, gets worse. So each subsequent time we're getting healing of that injury or re-injury, and making more scar tissue that is less than ideal. And the more scar tissue and re-injury there is, the shorter the interval before it's going to get injured again.
Yeah.
And then it gets to a critical mass where they can't keep the horse sound for more than, maybe a month or something before it goes on sound again. And then they come in, and by that time, there's a lot less that I can do to help them out. So, if it doesn't respond well the first time it became lame, then that's when I usually recommend the MRI, not the second or third or fourth time, because by that time, we've already accumulated some damage. The first time honestly just takes a bit more rechecks. So if your horse is lame, blocks localized to the foot, gets some shoeing redone, maybe some steroids or something. I usually recommend rechecking those horses a couple of times within a 3-month period. And if at any point during that period the lameness recurs, then we need to find out what soft tissue is involved, because or if there's a bad bone bruise, or if there's a bad joint injury, because those are the things we need to stop on and really rest and really rehab. If the horse has a little foot lameness, get some shoeing and trimming intervention, and the vet comes back in a month and it looks good, and it comes back in a month and it's back to more intense exercise and it's still good, then we're probably good. But if it comes back in a month and it's sound, and we increase the exercise intensity, and then in a month later it's lame again, in that 2-month interval, it's not handling the amount of exercise it needs. It may be subtle, but the lameness has returned. So those are the horses that I think probably need to get an MRI sooner rather than later, because there's a lot, if there is a deep digital flexor tendon injury, the prognosis is much better the earlier we catch it.
Right. Yeah. Yeah. Because it's just like a person, you injure a tendon, then you just keep injuring that same foot over and over, because it's like the weak foot. And if you don't rest enough to get it healed. We do have a question. Do you find horses with short or long pasterns tend to see more caudal hoof issues? Dr. James Rooney in his book, The Lame Horse, which is from 1974, and he was one of my advisors for my master's degree. So I'm sure we have learned a lot since then. He says that short upright pasterns tend to exacerbate pressure on the navicular bone, but wouldn't long pasterns cause more strain on the soft tissue up the back of the distal limb?
Yeah, so that's a super question. And if you think about it, especially if you just look at this picture here, right? We've got 2 pastern bones, our short pastern bone and our long pastern bone. And really what defines what our eye decides is the pastern is this space right here, right? Not really our pastern bones. And then what defines this space right here, a lot of times, is the horse's overall limb conformation. So what kind of hoof do they have? What kind, do they have a proper heel? Are they long toe, low heel, or they have more of a club foot? And then what is their conformation up higher? So a horse that, for example, has quite a long toe, low heel, and there's not a lot of support to their fetlock area. So if you look at them from the side and you draw a straight line down from the back of the pastern, there's absolutely nothing below them, right? We don't see, there's no heel, there's no shoe, there's no nothing. Those horses are going to have a little bit tougher time than a horse that is a little bit more upright. And so I think it really comes down to what the horse's overall conformation is. There's definitely long pastern horses, short pastern horses, and I think it really doesn't have that much to do with the size of the pastern bones, but really how the leg is put together that gives us sort of this impression of how much space we have in the back of the leg. So I do think, I don't want to put any of our predecessors down, because they were working with the best information they had and the best technology they had at the time. And we definitely have, you know, since 1976 or whatever, in that 40 something years, we have, I mean, we have MRI, we have CT, we have digital radiographs now. We have a whole lot more science that that they didn't have available to them. So I do think that it is a confirmation thing, but I don't know necessarily if the short versus long is necessarily true anymore, just based on what we know now.
Great. All right. So once you have come up with a diagnosis, then we get treatment, right?
Yep. So again, a lot of people get scared when they hear their horse has a deep digital flexor tendon injury, and I definitely think that any soft tissue injury in the horse is something that needs to be cared for very carefully, so that they get the proper time to heal. And I think that's still something that's up in the air, that we're still trying to figure out how long that really is. They can show no signs of lameness, but that doesn't mean that the structure hasn't healed completely. So certainly with any soft tissue structure, there's going to be a rest period. And I say rest very lightly. All of these horses, unless there's like a near catastrophic rupture to the structure, I like these horses to be moving to some degree. Because this is a very elastic tissue and it needs to stay elastic. And so they do need to be walking at the very least. I don't put them in a stall and leave them there. Number one, it's not good for their brain. And number two, it's not good that when there is pain in a horse, especially in the foot, they are going to bear less weight on that structure. And over time, so because of the length of this deep digital flexor tendon, if they're bearing less weight on this structure, it's going to become contracted and shorter. And then it's going to be much harder for them to stretch it out and have it be elastic. And it's going to be very painful for them to go through the process of stretching that out. So if anybody's ever had to wear a cast, and then they take the cast off and all of your tendons are just screaming because they've become contracted and haven't been used properly while you were in that cast, and it was painful for you to go through the process of stretching all those structures out. And that wasn't even the structure that was injured. That was a byproduct of wearing the cast because you broke your arm or you broke your leg or whatever. So I do like for these horses to be moving to some degree. Nice footing. If you live in an area where it's not too rocky, or it's relatively, if you're not living on the side of the mountain, on a shale cliff, then, take them out for a walk in the field, go for a trail walk, let their brains not be cooped up. Horses are very interactive and they don't like to be rested any more than we like for them to be rested. So I try to encourage people to do lots of different things. It's a great time to brush up on your groundwork. And when I stop, you stop. When I turn left, you turn left. And that kind of stuff. Walking over poles, really to engage their proprioceptive mechanisms, know where their feet are. All of that stuff can be done. You can do a lot of back exercises, a lot of back rehab, so that they don't lose their top line while they're just walking or only walking. Shoeing, I mentioned. Also, there are lots of things we can do as far as biologic medicine or regenerative medicine. So injection of platelet-rich plasma or stem cells or other serum products. Definitely you can treat the Navicular Bursa with corticosteroids as well. It's not usually my first choice. I usually would rather put a biologic agent in there, but it does get the inflammation out of there, which is what you're trying to accomplish. And then rehab. So certainly I like to do a couple of things here. Temperature is always a very beneficial and, again, very cost effective sort of rehab modality. So on the one hand, we want to decrease inflammation. So after a walk, I'm going to ice and get that foot nice and cool and cold. And then after that, I'm going to apply warmth or keep the leg wrapped or keep the foot warm in some way with a boot or something like that, because the increasing the temperature of the soft tissues will help them maintain their elasticity. So switching between warm and cold is always good, especially in the short term, right after the injury diagnosis or injury has occurred. And there's lots of other things. You can do some laser therapy, you can do some shockwave therapy, all kinds of different rehab. Probably what's most relevant to today, let me forward through my presentation here.
Yeah, while you're doing that, the person who asked the question about Dr. Rooney, she just wanted to correct her statement that Dr. Rooney said I'm not sure I can pronounce this word, entheophytes.
Entheophytes.
Thank you.
Yeah,
On
yeah.
the lateral and medial side of the navicular bone is seen in very upright pasterns.
That could be. So entheophytes are basically bony changes at the site of where tendons and ligaments attach. So on the corners of the navicular bone, so actually I've got this picture up. This is a cut through the foot. So we have our coffin bone, our navicular bone, and here's our deep digital flexor tendon right through here. And then this little space in between the flexor tendon and the navicular bone is where the bursa would be. So there's soft tissues on either side here of the navicular bone that help attach it to the coffin bone, as well as to the collateral cartilages to kind of lock that navicular bone in place. And so definitely the entheophytes can occur on these edges here at these soft tissue attachments. I think that it's possible for the entheophytes to sort of occur at areas of most stress on the sides here. I think that would also be possibly due to a medial to lateral imbalance of the foot. So if the foot is not balanced from inside to outside, then you're going to get more tugging on some of these soft tissues on the sides of the navicular bone as well. This is an MRI image. I was just kind of showing the three main structures there. And if you look at this deep digital flexor tendon on this particular view or scan, the deep digital flexor tendon is predominantly a black or dark structure. If we go forward, here is, so this is our cut through. That's how we're looking through it to get this view. And again, this is a little bit above the navicular bone, which is right here. But this is our deep digital flexor tendon, and you can see all of these white, gnarly, scar tissue-y changes to this deep digital flexor tendon that's there. But let me move on to this picture. So, and this is an example of some of what I have some of my deep digital flexor tendon horses do. It's not usually right away. So especially in an acute injury, I want things to stabilize and quiet down a little bit, get rid of some of the inflammation, maybe do some of my other modalities. And around the 2 to 3 month mark is when I start to employ the use of the wedged surefoot pad. And again, I'm going to start with the firmer ones and then move on to the softer ones. And this horse's foot is on the pad a little bit further than I would start. So I would probably start with just maybe the toe on the edge of the pad. And then over time, work the foot forward up the wedged part. And so this may seem a little bit backwards, but what we are trying to do is stretch out that deep digital flexor tendon. So again, it's running down the back of the leg and coming across around the navicular bone and attaching on the bottom of P3. And I know I just said that a long toe, low heel horse puts a lot of pressure on their deep digital flexor tendon. So why would I want to increase that angulation by lifting the toe? And my answer to that is that I'm not doing this permanently. I'm doing this for maybe 30 seconds, 3 repetitions, 30 seconds, 3 days a week to start with, and then gradually improving from that or increasing from that. And the idea here is that all of these tendon and ligament structures, when they heal with scar tissue. Everything that gets injured in the body heals with scar tissue. And so the normal deep digital flexor tendon is composed of collagen type 1, which is very long and linear and elastic. And it heals with collagen type 3, which is like a ball of yarn that has been rolled around and played with by a cat for an hour and is a big wad of fibers everywhere. And so what we're trying to do is get some, during that early stage of healing, give it a little bit of stretch to it to kind of encourage the healing of those fibers to be longer and linear and more elastic rather than jumbled up like a ball of yarn. So while I typically will put if I've got a long toe, low heel horse with a deep digital flexor tendon, I'll often put those horses in a wedge pad so that their heel gets elevated a bit. I'm using this pad as a rehab tool to get some stretch. So if you think about if you're a runner and you need to stretch out the back of your calf before you go running, what do? You walk over to the sidewalk and you put your heel down on the ground and your foot up on the curb, and you stretch the back of your leg out so that you can get the back of your leg nice and loosened up and more elastic before you go running. And so that's the same idea here, is I want this to get stretched out gradually and slowly without putting a lot of stress and strain on it. But I do want the foot to take on some of that stretch, and this seems to work super well. The horse obviously likes to stand on it. It's easier. You're not forcing them onto some tiny little block thing. And you can work your way up. So again, we're starting very minimally, and then over time, as the horse is tolerating it and healing quite nicely, we might get even more of a stretch out of them. And they may actually at some point say, hey, this feels really good. I'm going to inch my way up to be comfortable and put my foot where I want and really get a stretch there. And they may actually push the limits of time as well. So, if I start with 30 seconds, and then they take their foot off themselves and lick and chew, then I'm like, okay, well, that was a good amount of time. But if they seem comfortable and they're standing there and they're dozing off, maybe I let them stretch it out for a little bit longer, as long as they're quiet and comfortable, and then take them off. So every horse is going to be different. And again, the degree of the injury is also going to dictate how often they do this and how much they do this. So if it's a very bad injury, I'm going to wait a little bit longer, but I'm going to do more frequent but shorter bouts of it, versus maybe a horse that doesn't have quite as bad of an injury. I might start sooner and do longer stretches less frequently, in order to get what I need accomplished.
What's the average time? I know that they can all be very different, but the average time for healing this type of injury?
So every horse is different, but I will say that any injury that's within the deep digital in the associated with the navicular bursa takes a little bit longer. The deep digital flexor tendon, when it's within the navicular bursa, is surrounded by that synovial fluid, which slows down healing. So I usually say, even for a mild injury in the bursa area, I say at least 6 months. For a more significant injury, moderate to severe injury in that area, I would say anywhere from 9 to 12 months at the minimum. But I have had horses that I have had to go slow enough that they were not walk, trot, cantering for 18 months after the original injury, for a pretty significant deep digital flexor tendon injury. And then there are a subset that I usually, if it's a pretty severe injury, I will tell people that we may get them back to some level of soundness, but their level of expectation for exercise intensity, might be very mild work. They may only be able to be sound walking. If you start increasing their exercise intensity to start doing trot work, and and the deep digital flexor tendon just cannot take on that concussion, that stretch, especially associated with the navicular bursa, it's just going to create inflammation, and inflammation is going to create pain. And then you're back to square one. Even if you haven't re-injured the tendon, the tendon can't handle that level of work. So
we really do want to avoid these kinds of injuries.
Yes, absolutely. Yeah.
What's the number one recommendation to avoid this type of injury?
My number one recommendation is to get x-rays of your horse's feet, balance x-rays, so a lateral projection and a dorsal palmar projection of your horse's front feet, at least once a year, to make sure that the feet are staying balanced.
And coming out on Thursday to do that.
Yeah. Yeah. I think I honestly think that as part of your yearly preventative medicine, you vaccinate your horse, you deworm your horse, you get a Coggins on your horse, your vet's there, have them shoot some x-rays, mostly of the front feet, have them shoot some x-rays, and then have them share those with the farrier. And some years if everything looks good, then great, you're on the right track. But even the most skilled farrier, over time, the hoof growth changes, and they don't have x-ray vision. They can't see where that P3 is. And I think most farriers would relish seeing x-rays once a year or more of your horse's feet, to know that they're doing a good job. And if they do need to change something, they can change it. It reflects on the quality of their work, and I think most would love to see x-rays. So, if you want to do something very simple to help prevent injury, then that is my number one. And that prevents a lot of injuries in the foot. That the foot is 90% of our lamenesses, and you can see the balance, you can see how much sole depth you have, you can see the angulation, you can see a lot from those x-rays, and you can do a lot of intervention with your farrier.
So say the two views again.
Yep. So basically it's a lateral view, which means the x-ray camera is gonna be on the side of the horse. So basically this is a lateral view. So it would be shooting across from outside to inside. And then the second would be a dorsal palmar, which is basically shooting from front to back. So a side view and a front to back view.
Got it.
Yep.
Somebody's asking if this type of injury is mostly seen in the front feet, or do you also see it in the hind?
It is mostly seen in the front feet. The horse does it should be doing most of its work from the hind end to the front end, but they end up bearing more weight on their front end. Just naturally, even standing, they bear more weight on their front. And I think for whatever reason, the front foot balance is what gets out of whack a lot easier than the back. I do see a fair number of these in hind feet, but I think those tend to be the more acute injuries for some reason. And we definitely see more of this in the front. I would say it's probably a good, again, 80-20 split of all of our deep digital flexor tendon injuries. I would say 80% of them are front feet, maybe even higher than that are front feet.
Yeah.
Yep.
And it's I have to say, it's really great to hear you talk about these annual x-rays of the feet, because that's something that, hasn't really been in sort of the common thought. But having done so many of these webinars, so many of my farriers have recommended that you get, radiographs of the feet so that everybody knows where things are.
Yeah.
And, like you say, we don't have x-ray vision, and I personally am trimming my horses, the two I take care of and the one I own, so that's 3, and they all have such different feet. I've got a Clyde thoroughbred cross, I've got a Welsh cob, and a laminitic Connemara thoroughbred cross. And so I said just the other day, I want the vet to come out and take these radiographs so that I can see how I'm doing and where I can go.
Yeah. Yeah. I mean, if you as a horse owner give your farrier a Christmas gift every year or a Christmas bonus every year, instead, don't give him that dozen of eggs or that a Starbucks card or whatever it is that you give him, or him or her. And if you tell them I'm going to get x-rays of my horse's feet every year, that will be a great gift to them. This is a professional who's invested in horses' feet. They absolutely want to see what's in there. They want to see that they're doing a good job, or if they need to change anything. And so absolutely, I would say, if you want to be your farrier's best friend, start doing x-rays once a year. And I do think over time, again, technology changes our lives, and 15 years ago, people didn't have digital x-ray the vets didn't have digital x-ray all the time. They might have had computed radiography where they still had to take them on plates and then go develop them. Now, in 2 seconds, you see, is that a good shot? Yep, good. Let's keep it. Let's go around and take another x-ray. I mean, to take 4 x-rays of the front feet, 2 of each front foot, it's going to take longer for them to turn the computer on and start it up than it is for them to shoot the x-rays. And then they're going to get back to their office at the end of the night, and it's going to take them 30 seconds to send those in an email to you or to your farrier or to you, and then you send them to your farrier. And then both you and the farrier have digital copies of those x-rays. And if you save those images over time, you can see the changes that are being made in a positive direction.
Yeah. Yeah, I was at AAP in 2019, and I think we counted like 40 different booths devoted to radiographs.
Yep, absolutely.
Amazing.
Absolutely.
The technology that they have now.
Yeah.
Really awesome.
Yeah, absolutely. So,
well,
yeah.
Let's see. I think I have a question here. My trail riding horse is 24 years old, retired saddlebred, 9 years on the track. Multiple suspensory injuries and possible crack in pelvis. It's the only history I have. Have you done a webinar covering suspensory ligament injuries? No, I haven't. Maybe we have to have Dr. Kelleher come back and do suspensory ligament injuries.
Yeah.
Would you do that?
I would be happy to do that. Yes.
All right, great.
Yeah.
Cool.
My second favorite subject.
Oh, awesome. Great. Well, I'll
sleep.
have Alex get in touch with you to book a date in April, because that's it's just really helpful to talk about these things, and you've been marvelous, and so grateful for you sharing your information with us tonight. It's been really informative, and it's so interesting to hear it from your perspective, but to know that there's some simple things we can do to keep us away from you.
Yes. Absolutely. No problem. I would love to be obsolete someday.
Yeah. All right. So we'll get that hooked up.
Yeah.
So thank you so much for joining me tonight. And this has just been fascinating. I've really enjoyed it. And we'll see you back in about a month.
Okay. Thanks, Wendy.
Yeah. And thanks everybody for joining us, and have a great night.
Happy Monday. Thank you.
Yeah. Great Monday. Thanks. Bye.
Bye.